So I'll be talking in very short on 10 dictums which I follow while evaluating the cases of glaucoma. No financial interest. So first one is opportunistic screening. One should do whenever we get a chance. We must do the opportunistic screening to find out any glaucoma suspicious patient. Why? Because we know that with increasing age, glaucoma is more, and around 40 to 60% of patients are still undiagnosed. So we must use our tools to, in the best way, to detect those cases. We know that 97% of sensitivity is at risk group using basic visual tools. That was the finding of Zhao et al. In 2017. So if you use your tools correctly in the correct patients, in the correct high-risk patients, then there are more chances that you may land up in diagnosing more glaucoma cases. Number two is gonioscopy is a must. More and more cases are there of primary angle closure disease. PACG leads to more blindness, and that's why gonioscopy need to be performed even at the primary diagnosis and then also in consequential follow-up of the patients. So PACG is more visually devastating, high prevalence in Asian females, hyperopes, preventable with early intervention. So we shouldn't forget and we shouldn't allow gonioscopy to be done always. Then field analysis is another important thing. Must do at least 4 to 5 visual field in the first 2 years to find out the baseline as well as the trend of the glaucoma. That is only going to decide upon your treatment profile, whether you need to be aggressive, whether you need to be a moderate in your approaches. So change in the mean deviation of more than 1 decibel per year may significantly decide that the patient is progressive. The fourth one is structure meet functions. So dual lens approach, we have to correlate between the structure and the functions, and establishing a correlation between these two parameters is critical for diagnosing, monitoring progression and tailoring the therapy. These are the tools which are available for the evaluation. OCT is right now available everywhere. We can utilize the RNFL thickness and the GCC complex for better structural assessment. And then we have to use the tools like HFA or FDT perimetry for functional assessment. Now correlation becomes more obvious in the early stages. Structural damage often precedes the visual loss. So you'll see some changes in the structure, but you won't find more in the visual field. In the moderate glaucoma, correlation is more or less equal. But in advanced glaucoma, again, OCT goes to the floor effect and we don't find any changes, but the visual field goes on changing its paradigm. So the treatment, the guideline is both OCT and SAP should be done at the baseline periodically. Trend need to be seen rather than see the printout in isolation. 5 to 6 reliable field has to be done to find out those things. Then foundation of effective medical management in glaucoma is the medications. And these medications, we must remember the mechanism of action and we must employ in a judicious way to optimize the treatment protocol. So drug selection activity like patient factors, target, age, comorbidities, characteristic efficacies, drug rotation has to be done. Then other thing is that fixed drug combinations are now available which can give you leverage in giving maximal medical therapy and still preserving the patient lifestyle. Generic medications can also be utilized in the Indian scenario to minimize the cost. Laser procedures need to be placed at appropriate place, then only it is going to help you. Like in cases of SLT, if you give it in the early stages of treatment, the patient might have few years of glaucoma-free medication therapy. Then there are other like micropulse therapy, cyclophotocoagulation, they have to be employed at a proper place. The timely surgical intervention is again very important factor. Medical therapy or laser therapy fails, then we have to do progressive optic nerve damage which is not being controlled with the medications. Patient adherence is poor or acute angle closure crisis or congenital or secondary glaucoma. So the timing of surgical intervention is very important, but one thing is very sure that congenital glaucoma we have to do surgery. In cases of neovascular glaucoma we have to, or in the cases of secondary glaucoma we must treat the primary cause also. And in the other cases like primary open angle glaucoma, we have to employ our medical therapy first, lasers also, and if it all fails, then we have to naturally proceed for the surgical therapy. And these MIGS are changing the paradigm of the glaucoma therapy right now. So at least one should learn one of the procedure like bang to associate it with the phacoemulsification, or even in the primary therapy to add to the glaucoma treatment paradigm. And then finally, we have to also keep in mind the eighth one is the managing systemic comorbidities. We must not follow the we must follow these advices, like the patient nocturnal BP has to be evaluated. Why the patient is progressing, that need to be coordinated and correlated with what is happening with the patient normal systemic diseases. And follow-up is very important. So lack of follow-up is one of the strongest predictor of the glaucoma-related blindness. We must devise a protocol for each of the patients for seeing what has to be done. Just a minute. Then glaucoma status has to be done, recommended follow-up has to be given, and tool that aids our GPA has to be done, OCT trend analysis should be done. And in the first 2 years, the glaucoma, we must identify those progressions also. And finally, one has to do a good conversation with the patient regarding the glaucoma itself to motivate the patient to have a lifetime therapy for glaucoma in order to prevent these preventable blindness. Thank you very much.